So we are starting with this rather odd topic of discussion: distension in hysteroscopy. How much is too much? Now, since if we were to answer this question in one single word, the answer would be about 100 millimeters of mercury. But since the answer is not so simple, I've tried to put together some of the most recent references that cater to this particular topic before I give you my opinion of how the magic figure of 100 millimeters of mercury is reached. So we are talking of guidelines that have come out from the ESG, from the IAGE, and certain recent papers that address this very topic. So what exactly is the need for optimum distension in hysteroscopy? As all of you are already very well aware, the uterus is a muscular organ and its walls are opposed. The lumen is obliterated, unlike endoscopy of the bowel or esophagus, where there is already a patent lumen. So we need something to keep the walls apart and visualize the uterus. Not only that, unlike in cystoscopy, where once you distend the bladder, it remains distended, you need to maintain continuous visualization by an ongoing inflow and an ongoing outflow which is happening from the uterus. Add to that the problem of causing bleeding when you cut the uterus because of the blood vessels opening up, and there you have reasons to make sure that your distension is perfect. The problem of more distension, I am not going to details of this: pulmonary edema, electrolyte imbalance, hyponatremia, permanent neurological damage, we are all well aware. But if we work at lesser than usual uterine distension, the problem is of non-visualization or sub-visualization, and this in turn translates into surgeon fatigue and more time of surgery. So how do we get past this problem? Which procedures are the most challenging? Longer duration surgeries and those that cause bleeding. So hysteroscopic myomectomy, TCRE, and resection of the complete uterine septum is usually the problem area. Now, I think there is really no debate as to the choice of distension medium. Earlier, we used to use glycine, but the fluid and electrolyte imbalances are more likely with this kind of hypotonic solution. And therefore, now we've universally switched over to isotonic media where the complications are least. So we will henceforth be only discussing about sodium chloride or isotonic saline. When exactly does fluid overload occur, or what is the accepted limit of fluid overload? As per the IAGE, it must not happen in more than 0.1 to 0.2% cases. So it should not happen in more than 1,000 cases that you perform. The ESG is a little more relaxed. It says 5%. But a fluid deficit of more than 1,000 ml should be considered if you're using glycine. And they raise this to about 2,500 ml if saline is used instead of glycine. And so immediately you see that you get an extra 1,500 ml of space to complete the surgery. In patients with cardiovascular impairment or elderly, this goes immediately drops down to 750 ml. And ideally, the team should be checking the inflow and outflow every 10 minutes, or if not possible, at least at the end of every fluid bag that is changed. What are the factors that affect the absorption? The intrauterine pressure, of course. And naturally, when the intrauterine pressure exceeds the mean arterial pressure, there will be positive pressure or positive liquid that is going out from the uterus into the exterior. In addition, more than 75 millimeters of mercury is where the cutoff is, where there will be a lot of transudation from the tubal ostium into the peritoneal cavity. The second factor is the mean arterial pressure. If you have a patient with less mean arterial pressure, that means that you may have more absorption. So beware in patients who are elderly and have cardiovascular morbidity. Depth of myoma penetration. The deeper the myoma, the more you have to scoop it out, the more chances of fluid overload. What about duration of surgery? The longer the procedure, the more time required for fluid to accumulate within the body. What about the size of uterine cavity? Larger cavities provide a greater endometrial surface area and therefore are problematic. So coming down to the guidelines, how much pressure then is actually ideal? Optimum between 70 to 100 millimeters of mercury is what is recommended. For short procedures, you could use minimum 40 millimeters of mercury and you should be able to get through with that. Once the IUP exceeds the mean arterial pressure, significant amount of fluid can get absorbed. So 110 to 120 should be your uppermost limit. And remember that even if you're working at lower levels, pressure within the venous sinuses is much lesser. It's just 10 to 15. So cut open the venous sinuses and you have a fast outflow. In fact, in this RCT, they found that in two groups, If you control the IUP up to 40, you had no fluid deficit at all. But if you went up to 135, you had a fluid deficit of almost 1300. So now let us see that lower pressures actually may sometimes be useful. You don't really need to go to high pressures. For example, this particular case in which we are seeing that there is a submucous fibroid, but the submucous fibroid is greatly compressed by the high intrauterine pressure. As soon as you lower the intrauterine pressure, you find that this submucous fibroid, instead of being unapproachable, actually juts into the uterine cavity, and you can see the submucous fibroid coming more and more and more into the uterine cavity, and therefore it is easier actually for the surgeon to resect out this submucous fibroid than if he would have gone inside the cavity and tried to carve the fibroid out from the surface of the uterus. So working at lower pressure sometimes is actually advantageous. Similarly, take a look at this particular video. So we are trying to resect out. This is the same case. We are resecting the submucous myoma, and we are nearly at the end of the resection. You can see that the pink myometrium has come up. But after some of the resection has been done, this is the pink myometrium seen here. But after more and more of the resection has been done, you can see that there is another bulge that becomes visible below this resected area, which is now marked out by the red arrow. And if you can see this particular area right over here, you can note that this is a fresh fibroid, which the red arrow is marking out, which you would have never been able to see if you had high intrauterine pressure. The only way to get this fibroid out is to keep the intrauterine pressure very low. Yes, the field will get obliterated because of the blood, but you will have the fibroid coming to you, and in one single stroke of the resectoscope loop, you are able to detach this fibroid without wasting any time and without having excessive fluid overload. It also helps when you are doing synecholysis or lateral metroplasty. At the end point of surgery, as Rohan showed, just narrow down the pressure a little bit and you will see fine blood vessels coming up, which actually shows you that this is the end point of the surgery and that this is enough. This is time to stop the surgery and you've reached a good vascular. So in case you are giving too much of intrauterine pressure, you can never make out these soft markers. What are the pressure delivery systems that we are using? We are using simple gravity, pressure bags, or automated delivery systems. Can you still use gravity in present day and age? Yes. The achieved pressure is a factor of which is the width of the inflow tubing multiplied by the level difference in height. So elevation of the pressure bag by even 1 foot will raise the pressure by 25 millimeters of mercury. So what is recommended? Keep the pressure bag at 1 to 1.5 meters to achieve 100 millimeters of mercury.
Sorry to interrupt you, sir. 1 minute left.
Yes. Pressure bags are not outdated. Even the IAGE has recommended that start by using, if you're using pressure bags, the pressure estimation is not proper. So you could start high at 75 to 120, and that would give you a pressure of 50. It is not a direct correlation. We also have now automated pressure delivery systems like the Hystromant. I'm sure all of us are aware. But what we don't know is that there are better pressure systems like the Hystromant Easy. And what this does is it does not measure the pressure. It calibrates the pressure versus the flow. And because the flow is also estimated, you get a much better estimation of output. You also have systems that measure the inflow and outflow in terms of weight of the fluid and tell you that there is enough time to stop. Dr. Shauki could not deliver his lecture before, but he gives us an alternate view that you can use a very high pressure also, the advantage being that you get easier entry into the cavity and a clear field. But beware, for juniors who are not well conversant, this approach might be a little risky. So how do you advise, how do you minimize? Okay, so we can use vasopressin, preoperative GnRH agonist, and use regional anesthesia. In office hysteroscopy, you can go up to a maximum of 40 to 70 millimeters of mercury. And when you are doing hysteroscopy for endometrial cancer, reach up to a maximum of 40 because that should be enough. Thank you all for a patient here.